The anterior chest wall supports complex, dynamic glandular structures. The female breast presents a unique biomechanical challenge. It is a heavy, projecting organ resting entirely on the outside of the ribcage. To maintain its position, it relies on zero intrinsic skeletal support. It contains no bones, and it possesses no skeletal muscle. This 3D medical simulation of the anterior chest wall isolates the true support system. It is a specialized fascial network known as Cooper's ligaments. These connective bands thread continuously through the glandular matrix, anchoring the deep dermis directly to the strong pectoral fascia underneath. This hyperelastic design is engineered to handle decades of daily movement. Yet, during pregnancy, this exact network frequently undergoes irreversible mechanical failure. In clinical terms, we define this failure as ptosis. It is a specific, quantifiable collapse of structural integrity within the connective tissue. Ptosis occurs when precise endocrinological changes collide with extreme biomechanical forces, causing the fascial tissue to permanently yield. This process is defined in material science as viscoelastic creep. In this extreme macrosimulation, we observe the baseline physics. The healthy gold collagen matrix responds to a tension load by stretching and flawlessly recoiling. The tissue is anisotropic, its fibers specifically aligned to resist varied angles of force. This structure allows the matrix to absorb and distribute normal dynamic loads, like the sudden, fluctuating forces generated during athletic impact. Through the vital mechanism of biological recoil, the elastin and collagen fibers return to their exact resting length the moment the tension drops. Under normal parameters, this hyperelastic tissue endures significant transient stress without suffering plastic deformation. Early gestation introduces biochemical alterations that begin to change the integrity of the connective tissue matrix. The process begins with the secretion of relaxin, a peptide hormone primarily evolved to induce extreme laxity in the pelvic joints for childbirth. Relaxin acts systemically. This map plots the hormone's RXFP1 receptors, showing high concentrations in the pelvic floor and across the mammary suspensory matrix. When the relaxin binds to these specific RXFP1 receptors in the breast, it actively downregulates the synthesis of new collagen. The existing extracellular matrix begins to degrade. The critical crosslinks that give individual collagen fibrils their structural rigidity break apart. The mathematical result is a steep drop in the tissue's overall tensile threshold. Before any physical weight is added to the chest wall, the suspensory matrix is already biochemically compromised and primed for failure. This chemical softening occurs exactly as the body introduces a severe, unrelenting mechanical catalyst. Gestational glandular hypertrophy causes the lobules to rapidly expand for milk production, increasing the absolute mass of the breast. This comparative visualization demonstrates the difference in force. On the left, a fluctuating waveform of dynamic athletic load. On the right, gestational hypertrophy acting as a continuous, flat vector of static mass pushing downward. It applies an uninterrupted 24-hour-a-day downward force on the chest wall. This severe physical load compounds the danger because it is applied exactly when the ligaments are at their lowest chemical tensile strength. Neither the mass nor the hormone alone causes severe ptosis. It is the simultaneous intersection of static load and chemical laxity that forces the tissue beyond its limits. To see exactly how the structure fails, we direct our focus back to the microscopic fibrils of the now softened Cooper's ligaments. The tissue enters a state of viscoelastic creep. This is the slow, continuous deformation of a material placed under a constant stress that is below its normal yield strength. At the molecular level, the softened collagen fibers lose their grip. Depleted of crosslinks, they slowly slip past one another. This stress-strain curve plots the gestational timeline against the continuous physical load. The data line inches incrementally toward the red threshold marker of structural failure. As the pregnancy timeline progresses, the constant tension pushes the tissue to the point of absolute plastic deformation. The physical limits are finally breached. The tissue hits its exact microstructural yielding point. In this macro simulation, the anisotropic tissue stretches continuously, transitioning from a healthy gold to a dull amber. Individual fibrils begin snapping. Under the continuous static tension, the physical breakage forces the collagen bundles into a state of permanent, non-elastic extension. The macroscopic result is a transformation of the supportive fascial web into slackened, biologically inert bands of tissue. Viscoelastic creep has irreversibly destroyed the hyperelasticity of the suspensory matrix. The biomechanical failure is complete. Zooming out from the destroyed microfibrils, the macroscopic result dictates the final physical position of the entire breast structure. This structural collapse is often attributed to breastfeeding, a common clinical misconception. This visualization separates pregnancy from the postpartum lactation phase. The flat trend line shows zero correlation between breastfeeding duration and ptosis. This is explained by hysteresis. The return path of a loaded tissue cannot match its original loading path, resulting in permanent deformation. Unlike the external skin envelope, the internal connective tissue lacks the dense elastin networks required to eventually recoil after undergoing extreme, prolonged deformation. The microstructural yielding occurred during the gestational phase due to relaxin and static hypertrophy. Postpartum biological recovery is physically impossible, regardless of infant feeding choices. This permanent plastic deformation makes non-surgical interventions, like topical creams, biologically incapable of reversing ptosis. It also reveals why pectoral muscle exercises cannot lift the breast. Skeletal muscle contractions cannot tighten a degraded fascial web. This vector schematic demonstrates how surgical mastopexy functions as a direct mechanical intervention. The technique physically resuspends the tissue, artificially anchoring the slackened matrix back to the chest wall. This bypasses the failed biological recoil, creating a synthetic replacement for the ruined suspensory matrix. The sequence of failure is rigorous. Relaxin-induced collagen softening creates vulnerability, and gestational static load exploits it through continuous viscoelastic creep. Ultimately, the complex biomechanics of pregnancy characterize breast ptosis as a predictable, quantifiable, and completely irreversible failure of structural physiology.